So I'm going to give a much more basic overview of the kind of not so complicated treatments that would be really good to be available to the majority of people who had a substance use disorder. That are not so difficult that they couldn't be provided almost anywhere in the world, and most of which are outlined. I'm going to kind of show you a few of our publications as we go through, most of which are kind of summarized in this book, the MH Gap Intervention Guide, which has a chapter on drug use, which is very basic and contains a really basic version of treatment for non-specialists. And I'll refer to some others as we go through. And so this is not so much of a personal reflection on drugs, but some of the responses that the World Health Organization has had. So when we think of professionalization of addiction treatment, I think that we can think briefly about some basic knowledge base, the use of a common language for talking about substance use in terms of the diagnoses we make, a knowledge of what are the science-based treatments we're talking about, and some understanding about how we can apply them, what kind of system we need to apply them for that to be a professional service. As I said, most of it's outlined in this guide here. So I'm not going to go through all of this, but some of it may be a little bit obvious. If we think of the various types of substances that are in existence, it's not so difficult to think, for example, of the health effects and risks of cannabis use. With relatively small amount of training, most people we can bring people up to a level of knowledge of the short-term and long-term risks of the various different types of psychoactive forms, psychoactive substance use. In terms of the diagnoses, and these are really the language with which we talk about patients so that we know that we're talking about the same thing. In the International Classification of Diseases really has two essential diagnoses. One is harmful use and the other dependence. The idea being that dependence it's a pattern of behavior in which really this behavior takes over a much greater importance than it really should be in that person's life. And again, to make the diagnosis of dependence, you don't need to be you don't need to be a specialist with many years training or something like this. This is a kind of it's a simple concept that we think most people with some experience can come to quite easily. Then we think of what's the most basic intervention. It's a kind of brief intervention where the healthcare provider just has a discussion with the person who's using drugs. It can be from 5 minutes to several sessions, with the aim of reducing, stopping, facilitating engagement with a longer-term treatment process if needed, and often follows a screening process. It's very simple, and yet often we see reductions compared to control. And this is in a cannabis trial in 4 different countries done by WHO. There's 3.5 times the rates of abstinence following a brief intervention than following not. We see the effect is not quite as strong for more severe forms of drug use, such as for amphetamine-type stimulants or heroin. But nonetheless, it's a very simple approach that we think any person provider in a healthcare setting can learn to provide relatively easily. But it might involve a change of attitude in the way that they think about people who use drugs. It may involve a different kind of conversation, one in which it's less about saying in a kind of dictatorial fashion, you shouldn't do this, but to try and encourage that person to talk and then to communicate to give the feedback that this is a harmful thing, that this is, that you want this person to be healthy, but at the same time drawing that person into a relationship. And we see that this is also overall over illicit substances. There was an effect in the randomized trials that WHO conducted. And this technique is outlined in the ISSUP Guide to Screening and Brief Intervention. If we talk about more complicated talking therapies, more complicated psychosocial therapies, the science gets a little bit more complicated. For example, we did a review of this recently, which we haven't released just yet, and this was not an exhaustive list of all the different names, but there's a lot more that's happening that we don't get a name to. So really the process of talking to somebody with a substance use disorder, engaging them over a long period of time, can take these structured formats, can take unstructured formats, and part of the value is that it's just the relationship that is built with somebody who is socially excluded and then feels like they have a connection with the society. But when we want to look at what's the evidence for these, we need to categorize them into different areas. And so when we do that, you won't be able to read this. You see that there's about many different ways of categorizing them and breaking them down. And in the trials that we looked at, just to summarize it, CBT is effective compared to waitlist control. Motivational enhancement is also effective compared to waitlist control. Various combinations can be effective, and family interventions are effective, particularly effective for adolescents. So if I summarize these into a map, it's a little bit difficult to see. ND stands for no difference. So there are more than 100 trials of psychosocial interventions for cannabis. Almost all the pairwise comparisons show no difference because the trials were too small. However, you can see there's the family interventions, CBT and motivational enhancement showed a benefit. So we know then that for people with more severe forms of substance use, talking to them over a longer period of time, engaging in psychosocial support over a longer period of time does have a benefit. We looked at the same for cocaine and stimulants, and again, there is evidence for contingency management, family interventions, psychodynamic approaches, vocational interventions, the kind of employment projects we saw before, couples therapy. There is evidence for all these kind of therapies for stimulant use disorders, for cannabis use disorders, and for alcohol use disorders. For opioids, we have some medications which are particularly effective, most of which are outlined in this book here on the guidelines on the treatment of opioid use disorders. So naloxone is a very cheap medication that can be life-saving. If somebody overdoses, if you give them naloxone, they wake up within about a minute and a half. Now, in many countries, naloxone is not available, or it's only available in hospitals, it's not available in ambulances, and it's not available beyond ambulances. And we would recommend in our most recent guideline on this issue that if naloxone is available, you should carry it. If your son or daughter is a heroin user, you should carry it. If you know people who are heroin users, give it to them, let them carry it, and so that the first person who finds that person will be able to provide them with the naloxone. It's a very simple and effective approach to reducing the main cause by which people die from opioid use, which is opioid overdose. Methadone and buprenorphine, long-acting opioids, which can be taken once a day, or with buprenorphine once every second day, produce very stable levels of opioid and can reduce the levels of exogenous opioid use. They don't produce the kind of intoxication that people have with short-acting opioid use, and they're extremely effective medications at keeping people with opioid dependence alive and not using illicit opioids. So I won't go through all the medications, but there are a bunch of medications which are effective for substance use disorders. They are, in many cases, much more effective than medications routinely used in other fields of healthcare. And yet we still have difficulty getting access, people have difficulty getting access to them. Often there isn't a market incentive. It's not seen as an attractive area for pharmaceutical companies to go into. And so we have a bunch of useful medications, both for opioid dependence and alcohol dependence, which are not available to people who need them. Just to mention again, the difference between methadone and buprenorphine and heroin. As you see, that with the short-acting opioids, the highs and lows are very difficult to manage with that in a non-disruptive way. If you have that level of sedation and that level of withdrawal, it's very difficult to function normally. You may still be tolerant to opioids. In fact, methadone works by inducing opioid tolerance, but you can function normally because you don't have the highs and the lows. So it's not about whether or not you have a tolerance to the opioids, it's whether or not the level is stable. And again, this has been demonstrated to work in a bunch of lower income countries, including Thailand, as part of a multi-country study that WHO conducted. Again, the medications for alcohol dependence, I know that's not the subject of this conference, but many people with drug use disorders also have alcohol problems. And there are effective medications available. They can be cheap, but I've had it expressed to me that in Thailand many of these medications are not available, for example, primarily because there's no pharmaceutical company which is interested in promoting them. So there's useful medications for management of stimulant with stimulant overdose and delirium, benzodiazepine withdrawal. There are not a huge amount of medications. There are a few medications that everybody working in the field should know about, and even if they're not able to use them, should be aware of the situations in which they are useful. And this is the kind of basic skills which we can expect anybody working in the field to learn. There are some particular issues to consider about the treatment of special populations, for example, pregnant women, where the interventions, you can have a significant impact on the life of a future generation. And again, these are, some of the steps in this are outlined in the document that we've produced on pregnancy. Another aspect of professional treatment is to be aware of the common medical and psychiatric comorbidities. As Gilberto mentioned, rates of psychiatric comorbidity are very high: depression, psychosis, stress disorders, delirium, ADHD. There are very high rates of psychiatric comorbidity. There are also very high rates of medical comorbidities. For people who are opioid dependent, they often, if they don't die of opioid overdose, they die of TB. Even if they don't have HIV, TB it can be a major killer in many different parts of the world. And yet we often don't think about what to do if somebody coughs in a waiting room, for example, of a methadone clinic. So we don't need to be specialists in this area, but we should have a basic understanding of what are the common medical and psychiatric comorbidities. Maybe we can bring in some routine procedures to pick them up and to know how to refer to them if needs be. Of course, the most effective way of treating multiple comorbidities is the kind of one-stop shop approach. And this is a treatment center in Tanzania where a treatment center for heroin users, where people come in, they get their methadone, they get the TB treatment or isoniazid prevention therapy, they get HIV treatment if they need that, they get psychosocial support if they need that. They have testing all in the one place. And this dramatically improves the treatment rate of HIV, for example, which at the moment globally only 6% of people with HIV, of drug users with HIV, are receiving the antiretroviral treatment, compared to 50% of the general population, because of the difficulties of coordinated care. So we don't have to be specialists in all form of treatment, but we just have to work with other people who are, so that we can provide a simple and accessible treatment service that meets the treatment needs of the people that we're dealing with. Another aspect is to prevent the harms from drug use. People who inject drugs will are most likely to continue to inject drugs, hopefully they may stop, but if we provide them with sterile injection equipment, in the meanwhile, we can prevent them from getting HIV and hepatitis, for example. So these are, in a nutshell, these are the basic treatment options that we have in our armamentarium. But in terms of professionalization of a treatment system, we need to think about some aspects that aren't always present in a non-professional system. The concept of first doing no harm. What degree of, to what degree are we keeping the records confidentiality? The general assumption in a healthcare system is that all information is confidential. So we don't give it to the police without a judge saying that we need to, for example. It's only if there's a few limited extreme circumstances in which we may breach confidentiality. How do we provide a confidential service in a village where if we have a drug use clinic above the door and somebody walks in, then everybody knows then that person has a drug use problem. So we need to think about these issues in the way that we organize our services. We need to think of the concept of informed consent. That the assumption, again, for healthcare provision is that treatment is provided with informed consent, that there are medical records kept that are accessible and confidential, and that the treatments offered are science-based treatments, and that the advice is impartial. So, for example, we went through this process with Nigeria recently to develop treatment standards based for a discussion on these issues with the treatment providers in the room, and I put up a list like this, and we went through them, and in that setting it wasn't routine for treatment to be provided under informed consent. There are many services which were routinely locking people up against their consent, and then there were other services that weren't, and then they had an interesting discussion between the two of them. The people who were locking people up thought that was the only way to do it, and the other people explained that there were other ways to do it, and then they had a discussion, and then they realized that they wanted their standard to say that treatment should be with informed consent, and that's the standard that they put in the Nigerian document. So we might need to think about supporting the development of standards for each country. So in many countries there is no specialist system. Where there is only a limited capacity for specialist system, really the effort of that system should be to support the lower levels of the healthcare system, to maximize the opportunity for as many people as possible to receive some of these elements of basic healthcare which I've outlined today. The final element is that often care needs to go between different sectors. In the project we had in Cambodia, there were many people were being treated in the compulsory drug treatment centres, but the police often felt that there was nowhere else they could take them. So by training some of the local healthcare providers in some of the techniques we've talked about today, the police would then bring the drug user to the healthcare provider first, and then this reduced the demand for the compulsory drug treatments, just steering people away from the compulsory treatment to the healthcare option, which is more effective for the long-term rehabilitation. So that's just a brief overview of what's a kind of package of basic services which at the moment, as our estimate, is really available to a very small percentage of the world's population. And it would be great if we could really make this available to everybody who needs it. As Gilberto says, the same for any other condition. Thank you.